the class 2 restoration, but with the restorative being a composite. Composites are different from amalgams in a various ways. Number one, the preparation itself no longer requires there to be the reduction of the tooth to a certain degree because the material needs to have a certain thickness. Whereas amalgams were retained in the tooth mechanically with undercuts and grooves, the composite is a bonded system. Being that it is there are pros and cons to all types of restorations that we put in the mouth. With the composite, we normally determine if that is a good restorative material by the size of the filling itself and also the location. As you see here, there's composites on the bicuspid and the molar. They are rather conservative in nature. There is not a lot of tooth to be restored buccolingually. Another crucial thing about the composite is that it needs to have it's a little bit more technique sensitive. If there's any moisture or contaminant that get underneath the filling or in the filling during the not preparation, but to replace the filling, that will lead the filling to fail at a faster rate. Dr. Germani, go to the second slide. So then today we are going to talk about the indications, the preparation and the design. Of course, that isn't something that you are going to be doing, but you have to understand what the dentist is doing in order to restore it, the same thing as with the amalgam. With composites, we have a sectional matrix, which is a smaller, it's not the Toffelmeyer that goes and the band all the way around the tooth. They have actually made a matrix system specifically to enhance the longevity of the preparation by getting a good contour, by getting a nice embrasure. Definitely what is very important is at the gingival margin that there is a seal, because if there is, this is probably a test question down the line, if there is a failure, it is going to happen at the gingival, at the box, at the gingival area. Then we're going to talk about composite placement. Of course, like I said, it's somewhat technique sensitive. The composite needs to be placed in a certain way to achieve the highest result. Finishing and polishing, and then we're going to briefly discuss custom tinting and opaque. Dr. Germani? Okay, as I mentioned, the preparation of the tooth, one of the advantages are that the only thing that the dentist needs to do is to get to the decay, access the decay, and then remove the decay, and then the surrounding tooth have the minimal amount of reduction. So we're looking at small to medium size. Could you go back, Dr. Germani? Small to medium size restorations. Normally, because of isolation, it is best to do them on premolars and molars. The second molars, though, also can be restored. You just have to make sure you get proper isolation. And obviously, you do not want the patient to be biting down at the junction between the composite and the tooth, or primarily on a weak, meaning a marginal ridge, or the contact point on an area that is likely to break down. And of course, isolation needs to be achieved. But isolation doesn't only need to be achieved with the rubber dam. There's other ways. I don't know if your offices use isolite. That is also a satisfactory way of achieving isolation with the isolite and the suction. I've done it in my office. The next slide. Okay, so here we are looking at the different types of preparation. From the conventional one, as I mentioned, it looks to me like that first premolar had an amalgam because of the preparation design itself. And as you see on the first area, on the first picture, there is at least 0.5 millimeters of clearance, whereas the slot preparation down below, you notice that there is less clearance, because with the sectional matrix system and the way that the composite gets packed into the tooth, you do not need that much clearance. Again, more of a conservative restoration.
If I can ask a quick question here.
Yes.
So the black decay that you can see in that tooth, so that's not decay, that's just a stain. Or that's just arrested caries, correct?
Yeah, when I looked at it, and even when I was lecturing, if I had a tooth that had distal decay, and on the occlusal, I checked with the Explorer, and there is no stick, but there is this discoloration. It is a judgment call. Either I leave it alone and I tell the patient, brush occlusally very well, apply some fluoride, or if I start to feel a stick, then I would do the distal restoration in composite, and then occlusally, I would just remove the staining up until, even if I'm still in the enamel, etch and then put a sealant.
I see. So what you're saying is you would extend the box to include the stain.
No, I would not extend the box. What I would do is I would take a very small round burr and just right on top of, let me see if, yeah, can you see my arrow? Right on top of here and here, I would remove that stain. This one is very little. I would just remove it to the point that if I'm still in the enamel, I would etch it. I would put in the sealant. Another thing that we're going to be discussing is the flow of the composite. That is also a material that you can use. We are trying as much as possible to not remove tooth enamel.
Okay, so from what you're saying, I'm understanding that you would take a round burr and you would I just drew on the screen.
Yes,
can you see that?
Very, very small. I would
very small.
Very minimal reduction. And that is even if I feel that I want to touch it. If it's only stain and I touch it and it's hard as enamel, I leave it alone.
So that's called arrested caries, correct? If it's hard and it's not soft, it's arrested caries. Got it. Okay.
There is always time in the future to put a drill to the tooth. And in my opinion, if the further down the line in which you have to put the drill to the tooth, the better it is for the patient. Okay. So now we are going to be taught the composite has to be placed in a certain way. It is more conservative than the amalgam. So now the composite here, we're looking at that with the amalgam was placed, as they say it, micro-mechanically. The composite is placed macro-mechanically with the amalgam. With the composite, it's micro-mechanically, which means that the dentin and the enamel if the preparation goes all the way to the, as you read here, the sealant is used with composites in the slot preparation and design because probably this tooth occlusally had stains and they put in a sealant. So when the tooth is prepared and the enamel and the dentin are exposed, depending on the location and the depth, you as a provider that is going to be restoring the tooth will have to determine what materials are used. I know that you guys have already discussed the GI cement as well as just a straight flowable composite or just the packable composite. All of these that I've mentioned are retained. First of all, the GI cement bonds very well to dentin. The composite bonds better to the enamel. Therefore, if you have a very deep preparation, you want, and we'll be discussing this down the line, you want to have the GI cement be bonded against the dentin because that's when you're going to have the highest bond. Then on top of that, because the GI cement has its limitations, and the composite then can be placed over the GI cement and it is bonded to the enamel, which is where the composite itself has the greater bond. So we can go to the next slide. Okay, so we'll talk about composite. Like I said, this isn't something that you'll be doing, but you have to understand. With the amalgam, we were interested in sharp line angles. We were interested in when we're packing the amalgam to pack it into the retentive areas of the preparation before we start filling the occlusal. Remember how I said get the amalgam into the box and do the stepping motions. You also need to have at least 0.5 millimeters of reduction in the box area, and that is going to compensate for the matrix band that you have to slide against the tooth, of which then you need to have a wedge to make sure that the material doesn't flow at the gingival surface, and plus you want to establish a good contact. The composite, we're looking at rounded angles internally for two reasons. Number one, you don't need to have it mechanically retained in the tooth. You don't need those undercuts. Plus the fact that when you remove the decay, and if it's an oval of a shape, which usually, decay usually doesn't have a box or a rectangular shape. It's mostly fuzzy and it's rounded. So you just remove the decay to the point that you have, the dentist that has reached a point that he or she has hard dented. At that point, you don't also need to break the contact point because we're going to be reviewing the matrix system, and we'll get into that. And also, you do not want to remove more tooth structure than necessary. So to the next. Yes. Okay, so now we are, like I said, when you're going to be sitting down and you need to restore the tooth, um, depending, maybe the dentist that you work with is going to tell you A, B, and C. But then over time that you're going to be doing this for a while, he or she is probably going to let you decide. The reason we are going to be doing a closed sandwich technique and the other one is an open sandwich technique is going to be determined solely by the amount of enamel that the tooth has left once the preparation is finished. If you have enamel at the gingival edge here, composite is a better material to bond to ensure that there is a very strong bond there, because like I said, this is the area that the bacteria, the lack of flossing, or etc. is going to have the biggest assault, if we can use that word. Therefore, you have a deep preparation. You want to make sure that you don't have any pulpal sensitivity, plus the fact that you want to have the strongest bond. Here is the GI cement, a glass ionomer base. Okay, so it is going to be placed, the area is going to be cleaned, there's going to be a conditioner that you place, and then here is the glass ionomer base. Then on top of that, the glass ionomer needs to be prepared in order to accept the composite. So there is it depends, there is a 1-step or a 3-step system, but you prepare you prepare the glass ionomer, and at that point you bond the composite to the glass ionomer. So here we have layers. We have a very good seal here because glass ionomer bonds to dentin, and then we have a good seal because glass ionomer does not only bond to dentin well, but as well as composite. The composite then can be finished, can be contoured, and can withstand the occlusal pressures that the glass ionomer can't very well do. So here we have positive on top of positive in the type of material that is being used. So we can go to the opened sandwich technique. Correct. You have to have enamel in this location. If you do not have, we're jumping ahead. Let's go to the open sandwich and I'll explain it because I'm going to explain it in the second slide. Okay, so here we go. Now, all of a sudden, you see that the preparation has gone beyond the CEJ, the cemento enamel junction, right? So here, if I bond composite down here, I am not bonding composite to enamel. I'm bonding it to dentin and to the CEJ. What if I can ask you, I'm going to ask you guys a question. What is another preparation that we have prepared, but we've prepared it with amalgam? but still, what other type of preparation do you think that, rather than using composite, I would use glass ionomer? Would you do it on a class 1, which is the occlusal? No. On the class 2, yes, because depending, like I just said. How about the class 5? That you see the patient that for whatever reason at the gingival area is a class 5, that it's a little bit on the enamel, but mostly the preparation goes down along the root surface. Do you know what I'm talking about? Like over here, Dr. Germani, if you can make a line from here to here. Those, yeah, right over here. A patient has recession. Well, yeah, a patient has recession. So the gums have pulled away and then the decay starts there, but you see it's below the CEJ, so it's on the root surface. That is also a good indication that you could use glass ionomer. But back to the open sandwich technique, okay? We have a preparation, it's too deep. So what do? What are the properties of glass ionomer base that makes it a good material to use in this area? It releases fluoride. It is happy to be in a moist environment. Older patients who for whatever medication that they're on have a dry mouth, it would not be a good restoration to use because it would break down faster than necessary because it likes a moist environment. So here we go. We have no enamel, we put in the base, and then on top of that, because like I said, with even the closed sandwich technique, we need to cover it with composite because that is one of the not strong points that glass ionomer material has. It does not do well under the occlusal forces. It also doesn't polish very well, and it is not aesthetically appealing. Any questions? Am I going too fast? Am I boring you? You don't want to know. Let's go to the next slide. I saw releases fluoride class 5. Okay, so now we're talking about how we contain the material. Okay, so I agree and disagree with the slide at the same time. Now they're talking about the Tafelmeyer, and the way that it is set up here, it's almost like it is not a good system. Indeed, like I said, all systems are good when they work well in your hand. I, for instance, still use the Tafelmeyer because that's what I learned with, and over the years, I have perfected it in my hands. At the same time, when I do cross over to the sectional system, I find it extremely easy. But that doesn't mean that if you don't have the sectional system in your office and the doctor only has the Tafelmeyer, that you're not going to have a good restorative result. It can be, in my opinion, both can be successful. But the only thing is you have to understand what we are aiming for. We are aiming for absolutely tight proximal contouring and contact. We are making sure, because with the amalgam obviously is not tooth colored. And you are going to see as you do these fillings, there are some times that you know that you have put in the material, but that the material is so precise in color as to the tooth surface, it sometimes is hard to distinguish once you have the composite in there, where the composite starts and ends and when the tooth begins. So it's best to not have to remove a lot of flash. It is best to, when you do the restoration, that you are very meticulous and you don't say, oh, I can polish that away. Yes, indeed, you can polish it away, but then you're going to add another layer of difficulty to the preparation. So with the sectional material, I actually have one here. Okay, the way that you are going to place it, and I don't know if you can see it, you have this instrument right here that is going to be the, can you see that? Can you see this? Okay, so you see these holes right here. That is where you are going to put the holder, and you can spread it. Do you see how far you can spread it? And this one, this one right here, this is rubber, so it pushes against the adjacent tooth, and it is creating a the embrasure. But in this one, unless it has this V shape, it is very difficult, right? Because that material is there to put a wedge in. So this system is creating the embrasure. It is pushing against the teeth interproximally to create the space that has to compensate for the matrix system, because you want to have a tight contact, as well as for at the gingival margin of the floor. So those are all very, very important. And if you do not have the system already in place, that is what you're going to create, you're going to have a substandard restorative filling, because there's going to be the embrasure is not going to be correct. There's going to be leakage, or the contour is going to be off. Obviously, let's review very quickly. If the embrasure is too big, you have food impaction. If you have an open contact, you had food impaction. Food impaction, or an area that is not cleansable, it is going to cause bacteria to accumulate, and therefore the filling may last for a while, but it's going to fail faster than when it should. The longevity of the tooth of the filling is going to be undermined. It says right there, contact so tight that you need a hemostat to get the band out. Technically, that should be true for all restorations that you put in, amalgams or whatever. The height of contour, the contact of the height of contour is already going to be established because of the way this band right here and here push against the tooth. As you pack the mesial box, you're going to have the contact at the right position as well as the right height. And it naturally contours. That is what I will say that the Toffelmeier system does not do. It doesn't naturally contour around the tooth depending on the preparation. That is something that between the wedge and the burnishing of the Toffelmeier, you need to create. Again, here, of course, you have this system. It does many things for you, but in order to establish a good contact, you need to burnish this matrix band against the adjacent tooth. I think I taught this slide. Okay, so these are different systems. Actually, Dr. Giamani in the office has the gold as well as the silver. If you notice here, remember how I also showed you with the amalgam, you have these with the little, I call them rabbit ears, and that is if you have a very deep preparation. One thing though, it should maybe a question that you guys can ask yourself is, wow, this matrix system is so small. If I have an MOD, what am I going to do? Right? If you have a MOD, you need to have two. Can you go back to the previous? You need to have two of these. You need to have one system that does this contact, and then there are stackable rings that then you have the other same thing as this, but on the distal portion, because you need to prepare both boxes. You need to fill both boxes. Okay, so can we move on? Okay, there we go. I guess I jumped the gun. Here we go. They are using they're using a different system here, and they actually wedge. If you look here, they use two different sizes of wedges. And that's probably because of the contact. Okay. Place appropriate size, obviously. Insert wedge to create, and that's another thing that I forgot to mention. The wedges here are anatomically shaped. They're not the wooden wedges that we did in amalgam. They have, if you look here, they have a curvature here up on top, and that is going to, as they put the wedge in, it's going to make sure that you have your contact point in the correct position, plus also the same depth. So they have a curvature here, and if they would turn it around and looking at this, they have a curvature in hourglass shape also on the mesial and distal areas. Does that make sense? If it doesn't make sense, this is important. Please ask questions. Okay, so then the way you hold on to the matrix system is they have these little tabs. Okay. So there we go. Okay, obviously check gingival seal, burnish contacts. Here is a preparation. Here, for instance, we have an MO. Now, a question. I need somebody to answer this. Was this preparation, is it preparation for an amalgam or a composite?
Composite.
Composite.
Why do you say that?
The prep is rounded, not sharp.
What else? Now, if somebody said, I think it's an amalgam, I'm being a devil's advocate. Could there also be an argument or a discussion why it could also be an amalgam prep? Look at the access. Look how much clearance I have here, gingivally and lingually and buccally. It's definitely beyond 5 millimeters. You could say, well, the preparation was big. The isthmus, yes, here is, I would say internally there are rounded internal, it's rounded internally, so that's a composite. But the extension for prevention and the clearance gives me an indication that maybe there was an amalgam there initially. Now, obviously, that's another thing that you have to be aware of. When you remove amalgam, amalgam sometimes bleeds into the dentin and you get a black. The dentin is stained black. And many times, depending upon the depth or the location, sometimes it's a good idea to cover it with a flowable or a composite to opaque the color, because depending on how sensitive the patient is and how aesthetically, interested they are, that may be. Now over here, this, I would say that there was definitely decay there, and the dentist, it is for a composite, and the dentist just went in and made, they used to call them cat eyes. Probably not anymore, being the years of since I've been in dental school, but that is something. So that is something like, if you have a question on the board, just because you see internal line angles that are rounded, which, yes, you are clearly correct, that is a composite, there's other indications. You have to look at the whole picture. I hope they don't try to fool you guys that way, but who knows? Next slide, Dr. Giamatti. Okay, here we have, what is a potential problem with this slide, with the way they've done?
Has an open contact.
Indeed, indeed. And what do you think, and how do you think that we could solve that problem?
Burnish the matrix to close the contact?
That's one way. Dr. Kubis, what do you think? I can't hear you. Can you hear him, Dr. Giamatti? He's talking. Yeah, he's talking. I can't hear him. I'm sorry, Dr. Kubitz, I can't hear you. Another thing that you can do is maybe say, maybe my wedge is too big. Maybe I can achieve gingival, to have the gingival margin flush, but with a smaller wedge, therefore it won't push. The wedge is what is pushing this over. So maybe if you get the smaller one, or maybe it's the right size wedge, and then I need to have one of the prongs that I showed you that have space for a wedge. Maybe I can use one of these right here. Okay. There we go. They did what it's a Binting ring. I always forget the names, but I know what they're used for. So here we go. So the Binting ring is now placed distal to the wedge. And what it creates is it moves this matrix. It pushes on the matrix here and here, therefore creating a tight contact here, a nice curvature of the tooth. And of course, we know there's not going to be any flash because of the wedge. Yes, it's written B-I-T-I-N-E. Not biting. Binting. B-I-T-I-N-E. All right. Any questions? Okay. There we go. We need to burnish. Now, do you notice that when he's burnishing, this is opening up? So you're going to have flash there if he doesn't contour this, make this more snug. It needs to be snug like a glove, right? No excess. This one's okay. That one's he's opening up. Okay. Flowable. Here we go. We have prepared the tooth probably. Now, in preparing the tooth, and you see my the demonstration. Dr. Giamatti has purchased a one-step system. That means that the primer and the bonding are all in just one application. What I use in my office is a two-step system, where actually three, depending on if I want to etch then the edge of the enamel. It is a primer and the bonding that are separate. The reason why I have the 1 and the 2-step system is because when I am packing the amalgam, and I'm going to get into that, when I'm packing the amalgam, sometimes there is, when you're packing, the amalgam pulls out with your instrument. Obviously, you don't want that. So if I don't touch the primer, but I touch a little bit of the bonding to have the tip slightly wet. And then I touch the composite. It has it that the composite won't stick. It's definitely not Vaseline, but it's like a Vaseline. It will not make it stick. Yeah, so we can go on, Dr. Jamani. When you prepare the tooth, either one surface or the 1-step system or the 2-step, what you do with the 1-step is that you place the material, the liquid, but it has to be a very thin layer. You take your air water syringe, making sure that there is no water coming out. And the way that I normally check is I take my mirror and I blow the air. If there is moisture accumulating on the mirror, then you have to let the air just work for a while, and then you don't blast the tooth. You keep it at a considerable distance, and you just dry it to make sure that there is a very smooth surface of the material, but not clumps in area, just very light. Then you light cure it. The light curing, sometimes 20 seconds, sometimes 30 seconds. What is very important to know that every single time you light cure a material, there is shrinkage. It's called the C factor. It's the polymerization shrinkage. Therefore, some research has shown that the light cure can come out in a pulsating. It could be a stream. That's why at times they do 20 seconds and then stop and then go back for 10 seconds. This is all things to do to try to minimize the shrinkage. But there are other ways of getting around the shrinkage that I'm going to be going. So here we have the flowable. The flowable does a lot of things. Number one, it is a very good bond to the dentin. It also, for whatever reason, it does something to the tubules that if you put it, because I never have my patients calling saying, Doc, the tooth that you worked on is really, really sensitive, because I use the flowable. It makes post-operative sensitivity, and this is something very important. No doctor wants to get phone calls after the fact. The filling that you just put in hurts. It was perfectly fine before when I had the amalgam that was cracked. Now you told me to put in this white filling, and now I'm in pain. So we try to avoid that as well. The flowable composite seems to do a very good job at that, with my hands. And when I talk to colleagues and they say, I ask, did you put flowable? Sometimes they say no, sometimes they say yes. Sometimes the tooth is also just sensitive. So now we've put in the light cure, and we're going to go to the next step. You certainly may. Yeah, another thing now that we're going back to that, you do not, okay, the tubules have liquid inside, and what causes pain, right? The dentist, I could be drilling. Lots of times, for instance, I say to the patient, oh, it looks like a very shallow filling. Do you want to get numb? I can drill slowly, and if it's in the enamel, you will not feel pain. Okay, yeah, go ahead, doc. So then I'm drilling slow, but all of a sudden, I get to dentin. And all of it, the patient said, oh, I feel that. What are they feeling when I'm just barely touching the dentin? It's actually the fluid into the tubules that I am, with the handpiece, I'm drying out the tooth. And the teeth, and so the liquid is flowing up and down, and that is why patients have pain. Therefore, when you are working on a tooth, no matter what it is, never completely blast the air on it to make it completely dry. Because yes, the patient's numb, they're not going to say anything, but teeth are like elephants. They don't forget. Then when the anesthetic goes away, they let you know what happened to them. And I was treated a little bit too, drastically with the drying and the washing. So that is another reason why we have these primers and these bondings. Because in the past, the only thing we had was etchant, and dentists would put in too much too much etchant, and they would leave it in there for too long. And the only thing patients would say is the filling looks great, but it's very painful. And sometimes it would take months for them to feel better. And that's why the research has started to do now with, instead of just the etchant on the enamel, we do the primer and the bonding. They're trying to help us take care of the patients better. So then the next slide. All right. So here we're talking about finishing, okay? And as we discussed previously, there should be minimal need of this, because if you do the matrix correctly, you won't have flash. But if in case you do have flash, there is it looks like a very heavy sickle, but it is a very sharp blade. And what you do is you run it along the tooth. You never gouge inside the composite or the tissue, and you run it along the proximal wall, and it will slice away some of the composite. Of course, there are burrs, carbide burrs, proximal, the discs that you can then get into, but if you do use those, make sure you don't nick the enamel, and as well as cut the tissue. If the patient already has a lot of recession or does not have very thick gingival margin, and you use these, you can cause recession. So. Yes. Yes. I used to do that when I was in dental school. Yeah, I would protect. I would even keep the wedge in, so I keep the tooth separated. but I have to make sure that I don't get too much into the proximal area, because if the tooth is separated, right, and I'm cutting and I get overzealous, I can open up the contact. One thing that we have to go back, that it wasn't on the slide, but this is very, very, very important. When or maybe it's going to come next, because I haven't really talked about packing. No, now we're talking about finishing. We have to go back. Can we go back to a box? One of the ones that, okay, yeah, here. Okay, so here I have placed the flowable. Now I have to place the composite. The composite, when you have it, that it is the more solid composite, not the flowable. You are fighting two forces. Number one, you have to pack it, and number two, you have to take into account that every single time you light cure it, it's going to shrink away. So you're pushing it against the tooth, you light cure it, and it's going to pull away. Therefore, to minimize that, you do not fill the entire tooth with composite and light cure and then hope for the best. What you do is the same thing that we did when we put the amalgam in. We put a small amount in the box and we push it against the buccal and lingual walls, as well as the gingival floor. If you watch the other presentations that Dr. Germani showed you, the dentist actually made in this case, he would have made the mesial marginal ridge. And what he did is he packed, he light cured, he packed again, and he light cured, and he actually created a mesial marginal ridge. And then he said, what you can do at that point is to take all the matrix system off and then just do an occlusal. I would not say to do it that way, because you never know if once you take off this ring, if there's going to be bleeding. If you get moisture into the preparation, you're done. You have to start all over. But what is very important is, going back to the light curing, we're going to pack however you want. If you want to make a mesial marginal ridge, I don't have a problem with that. I would just keep the entire Bentine ring on. Then I would slowly, so here I have this all the way packed, just like we did with the amalgam, and then I would be adding a layer here, packing it always against the walls, because I want to have a very good seal all the way around here. So all of a sudden, and so now we're going to be packing. This is going to maybe take 3 to 4, even 5 packings. You pack, you light cure. You pack, you light cure. And so now the entire tooth has been filled. You take off this ring, and then you take the light cure again, and you bring it. Do you see here where the wedge is? You bring it to the lingual. You bring it to the lingual, and you bring it to the buccal, and you cure directly at that gingival floor. Therefore, as you were packing here, you have the light curing occlusally, but to make sure, when I take everything off, I do want to make sure that the composite is cured all the way down to the base of the preparation. So I bring the light buccally and lingually, and I cure it for 30 seconds. And then, of course, I'm going to use, what I normally use is I use a football carbide, and I make my occlusion. And the occlusion of the composite should be shallow. And it doesn't need, remember how with the amalgam I would always say, where's your central groove? It does not have to be that defined. It's going to be more of a slopes, mountains and valleys. It's not going to have one defined line in it. And that is different from the amalgam. And like I said, I'm going to refer back to the slides, the presentations that Dr. Germani put online. You can literally start making this anatomy when you're condensing with the round burnisher, as well as he shows that he is dipping the burnisher in the bonding, which makes the amalgam flow a little bit. Okay. And this is going to come a little bit clearer in the class when you actually come tomorrow and you're actually sitting there and doing the work. Control the environment, yeah. Well-placed matrix and wedges. You don't want flash. And of course, you know, I didn't review, but of course, when you're done, that contact to me looks a little shy, but you would use your floss. Now, I want to tell you, I have been a dentist for a long time, and 2 weeks ago, I was doing a composite, and it chipped. And what do you do in those instances? I did get a contact. It wasn't a really tight contact. I said to the patient, you know what? The filling just chipped. Do we want that? No, it happens. I drilled everything out and I started from the beginning. The appointment went longer than necessary, but I know that once that patient leaves, they're not going to call me and say something happened to your filling. If I let it go, this is just my philosophy. I don't want somebody to say, I was just there and now I have a problem. Sometimes it happens. Sometimes it breaks. I think the patients appreciate when you take the time and you say, I got to do it over again. Okay. Here we are, we're polishing. You have to be careful when you polish because you can even polish your contact to the point that it becomes open. Be careful how you place it in this angle. I would also maybe hold it occlusally, so the tip is coming here. It's touching against this tooth as well as that tooth. So it would be touching the contour of this tooth and that. In that way, the adjacent tooth doesn't allow me to open up this contact. Sticking this thing in there sometimes may. Okay. Another thing that some offices do, remember that Dr. Germani said that there is and here they go polishing. There are always, the composite is never going to feel as smooth as the enamel, no matter how much you polish. You can get very close, but obviously it's a different material. Therefore, there are some offices that in order to fill in these gaps, will use, again, a bonding system, just a bonding. It's a liquid, and you place over it, and you make it very, very smooth. It feels great, but they have found that then when the patient does chew and eat, it is not very strong, and it gets removed just from the occlusal forces. But at least when the patient leaves, they feel good, and it's nice and smooth. But just because it also leaves, that doesn't mean if your office uses it that you shouldn't use it. Okay? Do we have? Yes, there are polishing pastes as well. Yeah. That is a nice polished filling, but you see, there's no distinct central groove. There is, this is a valley, and the margins are nice. That's what I want to see. I want to see nice, adaptable margins. I want to see valleys and hills. I do not want to see contacts here. I do not want to see a contact here. I want to see contact in the pit. Okay, and then now we come to the tinting and opaquing. These are mostly done when you are doing anteriors that patients have the adjacent tooth that has some type of modeling, or the tooth isn't, from top to bottom one color. Many times these come in for cosmetics. They also will do this because you know how the central groove sometimes is of a darker color. And sometimes patients like that, others don't. See, it mimics the pit and fissures, crazed lines. These are mostly an application that you put on the composite. Okay. Does anybody have any questions? Okay. Okay. Correct. If there is contact, but when I put in the floss, it just passively, I don't hear a snap. I don't get resistance. I would now there's two things. Number one, maybe that is originally how the tooth was. If the patient had a light contact and I had put in the filling and the contact is the same as it was before, I would leave it alone. If I had a snap of a contact before and now it passively goes through, I would redo it. If I'm looking at the tooth and I notice, wow, there's a huge embrasure here on the lingual that I didn't notice it was like that before, because remember when I was polishing, I polished it a little bit off, I would redo it. It all, it all, it all depends. You can make, like here, this is a healthy contact. This one, I would say it's a little shy. I would try to make this contact stronger. But if when I'm filling the tooth, in order to make the fillings, the contact stronger from the contour of the tooth here, I have this big bulge here of composite. No, I want to establish a good contact without compromising. There is no point in me having a contact from here to here because I'm just packing in material, because right here my embrasure will be off and I'm going to have gingival irritation. There's a compromise there. But here and here is where the contact should be, right? If it's high, I would make it, I would say, okay, I need to adjust, wait. Right here, I would say, I need to check the occlusion. And this is another thing. Now, okay, say that here, here's my occlusion, I checked it, and I have a contact here and here and here. The first place that I would adjust is here, because I do not want the patient to be biting here. This is what we call a malocclusion. There are also sometimes when you have the patient tap, tap, tap occlusally, you cannot forget to have them go laterally from there's three ways of checking occlusion: straight occlusally, and then when you are asking, so here the patient's going, can you see, tap tap tap, then I go into your lateral excursions. Do you see that? And the lateral excursion, if I have this contact, I don't want that contact there. So I get rid of that contact. Then I say to them, tap, tap, tap. All of a sudden, can you get rid of that dot? Dr. Giovanni, can you get rid of it or no? Okay, say that the dot is gone. And now oh, no, keep those. Now I have a dot here, here, and then here. Give me a dot here, please. Or up here. It doesn't matter. Right here, this is not a good place to have. I want to have okay, this is also along this line. I do not want, if this dot was all the way at the cusp tip, I'm happy. So I would adjust here the dots that I do not want to see at all, which would be this one, which would be that one, which would be this one, here, here, and here. I would, and this one right here, Dr. Giovanni, I want it on the cusp tip. And here, I would adjust it so the patient feels comfortable. And you can also, after a certain while, you ask them to tap, tap, tap. You will also hear a sound that when they touch, that it sounds good. There's also a sound. It's interesting to say that, but over time you will notice. But here, another thing is the patient's numb on this side. And normally they'll always tell you, it feels high, it feels high, it feels high. What you have to do is you have to ask them on the opposite side. Are your teeth touching on where you're not numb? Yes. Do they feel normal there? Yes. If everything is yes, yes, yes on the opposite side, and you have proper occlusion on this side, leave the tooth alone. Have it that the contact points are like, you see, like here, this contact point is heavier than this one. I would have them all the same amount of pressure, of dots. If the patient is comfortable on the other side and they say this one feels weird, you say to them, go home, wait until the anesthetic wears away. If after a day it doesn't feel comfortable, come back and I'll adjust it. But you don't continue to adjust once you feel, I think I have it, because the anesthetic does, it doesn't mask it, but it complicates the patient from really giving you good feedback. Another thing is the patient laying back, feeling that it's okay, is different than having them sit up. So lots of times they feel okay when they're sitting back because their jaw is in a certain position, but then when you ask them to sit up, then they, I still feel something. I think so. And it also depends how their head is and how comfortable they are in the chair and everything. You know, their jaw, they may be biting. And then you have, which is a nightmare, you have the patient that every single time they bite, they have a different bite depending on the location. And there, what you have to do is you have to balance out of all of these different bites that you have, which one is to have it feel the most comfortable in all the different ways of biting down. Because sometimes they will bite and they touch here, and then you adjust and everything feels fine, but then you have them go into lateral, and then it comes, because you can actually see the way they're bringing their teeth together, it's in a different position. That Yeah, I forgot to mention, before you check occlusion, obviously you have to dry the tooth. For some reason, the occlusal paper does not work when it's wet. And there are different types of occlusion paper. There, where I work, it's the occlusal paper is like a horse ring that you put into the mouth, and when you ask the patient to tap, it will record all of the mouth. So if you use that and you notice that this is the only tooth that has dots on it, then you know that the filling is very, very high. But as you looked at the composite is better than the amalgam because you actually have more working time because you. So if there aren't any questions, I think we're done with the slides. Indeed, you are. Yes. Dr. Jamani, I just want to let the class know that I did get tested for COVID. I am negative. I am negative as of Tuesday of this week. I was never concerned because in the school, as well as where I work, we use the proper protection. And I just did it because I wanted to let you guys know that I did it and I have a result outside of just taking my word for it. Okay?
Thank you. See you guys tomorrow.
Thank you.
Bye-bye.
Bye.
Bye-bye.